Okay, so good afternoon, everyone. Good day, everyone. Welcome to this session. I'm really happy to have you guys today, and today we'll be entering into our next topic, which is gastroenterology. We finished reproduction last week, and so we're in gastroenterology today. And I think before the next class, we're going to do the slideshow for reproduction. I'm really sorry that I've not supposed to do it today. However, I'm a bit under the weather, so um, we're gonna start with gastroenterology today. For everyone that's joining in today, my name is Dr. Ois Mohamed Ohioma. I'll be your tutor for step one. So you're all welcome to the class. For those that are just joining in, I'm a very patient tutor, and so anytime that you don't get it or you don't understand what I'm saying, you can always call me back. I'm always going to go back and explain what I'm going to explain. Okay. Uh, so without further ado, we have to start the class. It's a 1 hour and maybe 10 minutes class. Okay. Simran, you can ask your question. Yeah, Simran. Yeah, go ahead. Dr. Simran. Okay. So okay, and so we'll be starting with the gastroenterology session today. Like I said, this is a class that I'm gonna be very, very slow to explain a lot of things that we may or may not know. So feel free to ask me at any point in time for your if you have any questions. The number one resource that I recommend for step one is actually the first aid. However, for some persons, first aid can be difficult to understand. And so that's why you need a tutor to help you over time as we go by. I'm going to still share a couple of resources that might be very, very helpful for you guys. And so we're going to start today. And so we're going to start with gastroenterology. So we'll start with gastroenterology, GIT system. And so the GIT system, we have the embryology, right? Embryology. We have the anatomy, ANC. We have
Hello, sir. I have a question. How long will this session be taking place?
okay. So I intend to finish it in 4 days. Um, I intend to finish it as fast as possible, but it also depends on how well you guys assimilated. You know, everybody has a different speed of assimilation, and so my target is 4 days. I intend to use 4 days to finish it, if even possible, 3 days, and so that we can go on to the next topic. And so that just depends on the level of how people assimilate in the class. That's what would really influence the duration of the class. And so, without further ado, I don't know if that answers your question. Without further ado, I'm going to be introducing the class gastroenterology. Today's class is basically the introduction. And so I'm just talking about the areas that we're going to be covering in the whole GI system. So we'll talk about physiology, anatomy, embryology, pathology. Pathology will be covered as well. Um, Pathology, right? And then we're going to end it with pharmacology. So this kind of like the outline we'll be going with, and you can still follow up. You can read ahead. You can read before the class. You can read so you can get updated with how we're going, and you can follow up. And so we're going to start with the embryology. This is the outline basically, but we're going to start with embryology today and a little bit of introduction, right? And basically, I'll start with this picture on first aid. This is a topic that I think we dealt with in reproduction when we we're talking about the pharyngeal arches, and I mentioned that we we're talking about the derivatives, right? Derivatives of the pharyngeal arch and pouch. I mentioned some structures basically, and so what you need to know for this part, it can be tested in the exam, and it's basically a picture of the tongue, delineating it into two structures. And so this is how it goes, right? And so the tongue has an anterior and posterior part in biologically, and it is assumed that this anterior to third, this is the anterior to third, originates from the first and second pharyngeal arch, right? First and second pharyngeal arch. So the first, second pharyngeal arch, first and second pharyngeal arch. And of course, it means that the blood supply and nerve supply to this part of the tongue will be gotten from the nerve that supplies the first and the second pharyngeal arch. And I mentioned in the reproduction class that the first pharyngeal arch is supplied by cranial nerve 5, and then the second pharyngeal arch is supplied by cranial nerve 7. What you need to know for the exam, and what I recommend that is very high yield, is to know that this anterior to third of the tongue, it has a sensory part and it has a part for it that is responsible for tasting. So there's general sensation, so there's taste, and then there's sensation. The part of it that's responsible for taste is the facial nerve. So the facial nerve supplies the anterior to third. It gives branches to the tongue, and it helps to sense taste. So whether the food is salty, whether it's spicy, whether it's peppery, you'll be able to identify that via tasting. And the cranial nerve that's responsible for that is the cranial nerve 7. But for the general sensation of the tongue, the anterior to third, so you want to check whether the food is hot or cold, general sensation, or pain. The cranial nerve that observes that function is cranial nerve 5. Like I said, the anterior to third of the tongue is derived from the first and the second pharyngeal arch. So the anterior to tongue has contributions from the first and the second pharyngeal arch. And I now said that the first pharyngeal arch, the nerve that supplies the first pharyngeal arch is cranial nerve 5, and the one that supplies the second pharyngeal arch is cranial nerve 7. I now further added that you can use the anterior to third of your tongue for two things. The first one is to taste, and the second one is to sense. When I mean by sensation, I'm talking about hot, cold, or painful stimulus. And that is carried out by the trigeminal nerve. And then when you want to taste something to know that it's spicy, salty, or whatever, and that is like the cranial nerve 7. That's the facial nerve. Now, the posterior part of the tongue here, this structure you see here, just kind of like circular, is known as the foramen caecum. And the foramen caecum is kind of like where the thyroid gland kind of like comes from. Yeah, so it's like the embryological precursor for the thyroid gland. And of course, the thyroid gland has to come down to the anterior part of the neck, and it has to go through the thyroglossal cyst. So once the thyroid bud comes off the foramen caecum, it has to travel down to the neck. It has to go down to the neck, and that duct is known as the thyroglossal duct, right? And when the thyroid gland gets to the neck, this duct has to be obliterated. A situation where you have a duct that is remaining and then a collection of fluid accumulates in that duct, you have a thyroglossal cyst. Okay. And so there are certain the cranial nerve that innervates both the taste and so the posterior tongue, right? This is very high yield. I want you guys to understand this because it's tested a lot in the exam. We have the sensation and we have taste. Now, when you want to sense, the cranial nerve that supplies sensation basically is the glossopharyngeal nerve. So the posterior part of the tongue is derived from the fourth and the sixth cranial pharyngeal arch. So sixth pharyngeal arch. And so the nerve supply to these arches is what will contribute to the posterior tongue. And so the glossopharyngeal and the vagus nerve supplies that region. Now, this is the posterior tongue. From this region back here is the posterior tongue, but there's a small space down here, just back of the tongue. So this is the anterior. This is the anterior. Below the red line is the anterior, and above the red line is the posterior. And then this whole part of the posterior here, just around the foramen caecum, is supplied by the glossopharyngeal nerve. Supplied by the glossopharyngeal nerve, right? And this area here, this area that's like just above the foramen caecum, is supplied by the vagus nerve, right? And so the glossopharyngeal nerve and vagus nerve help with sensation and tasting, especially the glossopharyngeal nerve. It helps with sensation and tasting. The pharyngeal nerve helps with more of sensation at the posterior part of the tongue. Glossopharyngeal helps with sensation and tasting. And this is commonly tested in the exam. It's commonly tested. So you should know these things I'm writing. Okay. And so there are muscles that you have to know that's kind of like move the tongues, right? There are two muscles you must know. You must know the genium glossum and the styloglossum. So stylo, how I remember stylo is that it starts with an S. And so what the muscle basically does, it's kind of like, when you want to say the words, you want to make that sound because your tongue kind of like goes upward and is depressed, kind of like, I don't know how to explain it. Let me show you guys. So you are like hissing and you want to like call out somebody, or you're hissing and you want to like call out somebody. That muscle that causes the tongue to kind of like go to the side and it's a bit arced upward. So let me just put it like this. The stylo helps with upward movement of the upward and side movement. So the side, just remember like the S in the stylo goes with the side. So when you want to move the tongue upward and sidewards, the styloglossal muscle does that. The genoglossal muscle does the opposite of this. It depresses the tongue and kind of like brings it outward. So depresses the tongue and brings it outward. Depresses it and brings it outward. Okay. At this point, do we have any questions, guys? Okay. And now we go into the embryology properly, and I'm going to talk about certain things that you guys should know. And so, the embryological foregut arises from the endoderm, and this is very high yield to know. The GIT tract comes out from the so the foregut or the GI is an endodermal derivative, so it's gotten from the endoderm. Doesn't mean that there are not some parts that are mesoderm in nature, but a majority of the structures that make up the GI are derived from the endoderm. And what I want you to know is that the foregut, the delineation of the foregut, which is what you must know for the exam, is that the foregut starts from the esophagus. A lot of people think it starts, well, some people say from the mouth, but it actually starts from the esophagus. It starts from the esophagus and then to the duodenum, the second part of the duodenum. So basically, where the pancreatic duct and the, the ampulla of Vata, basically, from the esophagus to where the ampulla of Vata is, or where the pancreatic duct drains into the duodenum, that is the foregut. Now, what I want you to remember is this mnemonic here called LAR. So this tells the position of the vagus nerve in relation to the GIT embryologically. So the left vagus nerve is located anteriorly, and then the right vagus nerve is located posteriorly, and that's how it is even in the embryo, even in an adult individual. And there's some very high yield changes that you need to know embryologically that about the GI that we need to know. You need to know that the umbilicus the umbilicus is like an opening between the GI tract and then the yolk sac, right? And so what happens is that as the fetus is growing, the GI tract is also growing. But the problem here is that the GI tract is going at a very, very fast rate. It's growing at a very, very fast rate as long as and it's going with the fetus. And the way the fetus is located, it's growing more anterior posteriorly in the womb. So it's not growing within the first week. The fetus grows more anterior posterior. How do I put it now? Craniocaudally. Let me use craniocaudally. So it grows more along this line. It grows this way, and then it grows this way. And so the GI tract is going up and becoming larger, and there's a very limited space for the GI tract to kind of like occupy. So the fetus is growing craniocaudally, and then the GI tract is becoming much bigger. But the problem is the fetus is not growing anterior posteriorly, and so there's a very limited space for the stomach and all other organs to go. So what happens basically around the 6th week or so, the GI herniates through the umbilicus. We call this physiological herniation. Please, can we mute our mics, please? Dr. Irene, can you mute your mic, please? So what I was saying was that there's what we call physiological herniation. And physiological herniation just simply means that around the 6th week, 6 weeks, physiological, sorry, let me write this one. Physiological herniation. Around the 6th week, because the space in the abdomen is kind of like little, the fetus is growing craniocaudally, but it's not growing anterior posterior. It's not expanding in width, but it's expanding in length within the first 6 to 7 weeks. So some part of the abdomen has to herniate through the umbilicus into the yolk sac. And this occurs around the 6th week, and we call this physiological herniation. And so when the fetus has attained a significant development around 4 weeks later after this event, 4 weeks later, 4 weeks later, when the fetus has grown more anterior posteriorly alongside growing more craniocaudally, um, God has a way of making things work. And at its time, in the 10th week, this part of the, what do you call it? Part of the intestine and all of that that herniated through, along with the peritoneum, goes back. And so, return of the physiological herniation occurs around the 10th week. This is very important for you to know. And then what happens is that the superior mesenteric artery, if you are very, very conversant with that artery, is the artery that supplies the midgut. And it's actually the midgut that herniates. And so the superior mesenteric artery forms a nidus, forms like a fulcrum, right? Forms a fulcrum through which the returning gastrointestinal tract that is coming back to the fetus rotates. So it forms like a kind of like a pivot point, right? For the returning midguards to rotate, right? And of course, when there's an abnormality in this return and rotation, you would have what we call a malrotation. We're going to talk about it as we go on that pathology. We're going to talk about it. It is postulated that the midgut, when it returns, is supposed to rotate at an angle of 270. And so if there's a process that affects the rotation of the gut as it returns back into the fetus, that can lead to malrotation. Okay? Is that clear, guys? Do you have any questions at this point?
Please, can you run it down again?
Okay,
Can you
so
re-explain? Yeah, thanks.
okay, so I said that I started at this point here where I mentioned within the first 6 weeks of life, the fetus grows in a craniocaudal direction. That means it lengthens, and so there's not enough space. It's not lengthening more. It's not lengthening anterior posterior. This is what I mean by anterior posterior. It's not lengthening in this way, in this direction. It's lengthening more in this direction, up and down. It's not lengthening front and back. Now the problem with that is that the gut is rapidly developing, right? It's rapidly developing, and so God has a way of making things work at their time. And so if he causes the midgut, which by volume is the has a very large amount, he makes the bowels go through this umbilicus and go into the yolk sac, right? And it carries along its peritoneum with it. It carries along its protective covering. Now that process where the midgut kind of like leaves the fetus and goes into the yolk sac, so that there will be enough space, for the growth, the anterior posterior growth. That process known as physiological herniation, right? Now, 4 weeks later, it is understood scientifically that the fetus now grows in an anterior posterior direction, and so there's enough space for the rapidly growing GI tract. And so around 4 weeks after that physiological herniation occurs, which occurs at 6 weeks, 4 weeks later, which is around the 10th week, the midgut returns back into the fetus. And now there's a lot of space for it to continually grow, right? Even though, because it's growing rapidly. And I now said that what happens is that the superior mesenteric artery forms like a pivot point. It's a pivot point through which the midgut that is returning back will rotate around it. And so you would have the right column, have the right column in the right iliac fossa, and then the left descending column in the left iliac fossa. The reason why that happens is because the superior mesenteric artery forms like a turning point for the returning guts that is returning back into the GI tract or the fetus around 10 weeks, right? And so if there's failure of that normal rotation to occur, such that the right descending column will be found in the right iliac fossa and the left descending column will be found in the left iliac fossa, if there's an abnormality in that process, we call that malrotation. That's what I'm trying to say. I don't know if that makes sense to you. Yeah. So the next thing we're going to talk about is abnormalities that have to do with the GI tract embryologically, and the two common ones that are tested in the exam, and it's a very high yield thing for you to know. I cannot emphasize this. It's commonly tested in the exam. There are a lot of that. I'm not sure there's any GI question that comes, embryological GI question that comes, that they don't test this. And it's actually between these two processes known as gastroschisis and omphalocele, right? Now, basically what happens in gastroschisis is that they are both ventral wall defects. So ventral wall defect. So the abdominal wall has a ventral aspect, and when there's a kind of like an inability for either the umbilicus to close or failure of those yeah, Dr. Zahur. Yeah, Dr. Zahur, you can ask your question. Okay. And so these two things, I'm just going to focus on the high yield things you need to know for the exam to pass your step one. You don't need to know everything. What you do need to know are things that would get you points on the exam. So I'm not going to stress on things that I feel won't help you in the exam. The most important thing about these two conditions that you must know for the exam is the location. The location is like the and the second high yield thing you need to know, or the three high yield things you need to know basically, is the location and then the covering. The covering. And in some rare cases, the association. Usually, how they bring this question in the exam is that they'll give you a picture of a patient, a neonate or a baby, and then you'll see some GI context outside outside the fetus, and they would ask you what's the most likely diagnosis, and that's how the question comes most times. It's as easy as that. And so you need to know the difference between the both of them as regards these three very high yield aspects. As regards the location, we know that the gastroschisis is located kind of para-umbilically. So this is the umbilicus basically. And so the lesion is usually found around this area or this area. And like I said, it's a ventral wall abnormality, So what happens basically is that the ventral wall doesn't fuse completely here. So it leaves this opening either here or here. You can't have it bilaterally. You can only have it at one side. So it could either be the left para-umbilical region or the right para-umbilical region. You cannot have it bilaterally, okay? And that for the omphalocele basically is kind of like a problem where, you know what I mentioned about physiological herniation, where I told you that the guts have to come back like in about 10 weeks of pregnancy. Omphalocele is kind of like an abnormality in that process. So physiological herniation happens, but it doesn't return back basically around the 10th week. And so this tends to occur more centrally, right? And so that's very, very important for you to know for the exam. These key things are very, very important in distinguishing the both of them. The second thing you need to know is the covering. And like I mentioned earlier on, the gastroschisis is a situation that the bowels are kind of like outside the abdominal cavity, but in gastroschisis, there is no covering, right? No covering. So there's no peritoneal covering. So the peritoneum doesn't follow the gut outside and kind of like protect it. But on omphalocele, you have a covering, and this is very, very important for the exam. And the most important thing that you might see in the question is about the association. This is very, very much high yield for omphalocele because omphalocele has a lot of crazy associations. You have the Beckwith-Mederman syndrome. I don't know how many of you guys know this. Any of you guys, can you tell me the triad of the disease condition?
Yes, and back
Zali.
with Weidman syndrome, we get the macroglossia
Yeah,
hemi-hypertrophy
yeah,
of the body, as well as
yeah,
Wilms tumor.
yeah,
Wilms tumor.
yeah. And then you can have omphalocele as an association with it. Yeah, that's the association with that syndrome. Omphalocele is a strong association that's commonly tested in the step 1 exam, and it's something that you must know. You cannot go into the exam without knowing that omphalocele is a strong association with Beckwith-Wederman syndrome. Another thing that I must say that is also very high yield for you to know in the exam is that there are certain trisomies, and they can confuse you a lot because the two trisomies that are associated with this guy is 13 and 18. Sometimes in the question, they might put trisomy 21 to kind of like lure you out. Trisomy 21, which is Down syndrome, has its own association and it goes by the mnemonics of Chad. The GI conditions that are associated with Down syndrome, I call them Chad associations. The ones that are associated with chromosome 21 abnormality, which is Down syndrome. And I'll just quickly just talk about them basically. I'm going to list each and every one of them so that you can just know it. The C you have there is, right? The C there is congenital or congenital. Let's start with the H first. The H is let me just remember that. So this here is a diaphragmatic hernia. Let's start with the D. The D is a diaphragmatic hernia. So diaphragmatic hernia. The H is hypothyroidism, congenital hypothyroidism. Right? The A is annular pancreas. Very, very high yield, annular pancreas. The H, you can either have congenital hypothyroidism or you can have hypertrophic pyloric stenosis. Right? You can have it there. And then here you can have congenital umbilical hernia. So the chart basically are the common associations that are tested along with Down syndrome in the GI. And so typically how the question goes is that you'll be told about a patient who has maybe Down syndrome, and they might tell you that this patient is at risk of what basically, or what would you want to screen in this patient. And so if you know this like 4 association, you are home and dry. So congenital umbilical hernia, they call it hypertrophic pyloric stenosis, annular pancreas, and diaphragmatic hernia. And so we'll talk about each and every one of these when we get to that stage, but this is something you must know. Okay, so does this make sense, guys? Okay, so let's go on. The next one we're going to talk about is the congenital umbilical hernia, which is also very high yield. I told you that it's associated with Down syndrome, and what basically happens in the congenital umbilical hernia and how you can differentiate it from a omphalocele, because it's the same mechanism, pathophysiological mechanism. You know, there's herniation through the umbilicus, but the only difference is that in omphalocele, you have that the herniation is covered by a sac, but in congenital umbilical hernia, it's covered by the skin. And just to kind of like tell you guys, congenital umbilical hernia is commoner in Down syndrome and congenital hypothyroidism. So in these two conditions, how I want you guys to see it is that you should prime your mind. You see a patient with a hernia, they might just give you a picture of a child, right? And they might just show an arrow to the umbilicus, and they tell you that the patient has a swelling that is worse when the patient coughs. And they might ask you, what is this patient at risk of having, or what other association would you see in this patient? And of course, you should know that Down syndrome, congenital hypothyroidism are very, very high risk, a high yield association you should know for the step one. Okay. Do we have any questions at this point? Okay. So the next thing we're going to talk about is a also very high yield topic. Embryology for GI is very high yield. A lot of things that they can test. Okay, yeah, sure. Go ahead and ask your question.
Sir, can you please repeat the child mnemonic?
Okay, the child mnemonics, yeah. So the child mnemonics basically is that we have, this is the child mnemonics is for association with Down syndrome. And then the congenital umbilical hernia is the C. Then you have the hypertrophic pyloric stenosis as the H. You have the annular pancreas as the A. And then you have diaphragmatic hernia as the D. Okay.
Thanks.
Yeah. So we move on to the next one, which is kind of like, I've talked about the congenital umbilical hernia. I told you what's associated with. I told you what separates it from omphalocele. Omphalocele is covered by a sac, peritoneal sac covering. Congenital umbilical hernia is covered by the skin, right? And I told you about the association with this guy. I mentioned those two, Down syndrome and congenital hypothyroidism. Those are the high yield things you need to know for the exam. Now, the next thing we're going to talk about is tracheoesophageal fistula. This is another very high yield concept I want you guys to know. And the questions that are commonly asked in these questions are, we have three types basically, right? We have three types of, so this is, the thing is that the GI tract and the respiratory tract share a common board. So basically, the GI kind of like boards off the respiratory tract. Well, I don't know if it's the other way opposite. Yeah, kind of like boards off the respiratory tract and comes down. I think it's the other way around. No, the respiratory tract boards off the foregut. Sorry, it's the other way around. So the respiratory tract kind of like boards off and starts growing and forms the trachea and all of that. And so an abnormality can form when there's a septum that kind of like separates the GI tract from the respiratory tract, right? And basically that septum kind of like completely divides the two systems. But a situation where there's kind of like a connection between the respiratory tract and the GI tract, the patient will come down with tracheoesophageal fistula. And how this is tested in the exam is that they can tell you, the way the first question can come is that they will tell you about the three types. So we have three types. Sorry guys, my network, I got a call affected. Yeah, so where was I? Yeah, so how it's tested in the exam is that you'll be given I want to talk about the three of them first of all, right? So I'm going to talk about the second one, that's it's called the H type, right? So this is the H type. And then you have the last one where you have something like this. This is the trachea. And then you have a connection here with the GI tract, and then the proximal end forms as an atresia. So this one and this one kind of like together makes about 15% of the tracheoesophageal fistula, and this one forms about 85%. So how they usually put it, basically, in the question is that they will ask you the most common type of tracheoesophageal fistula. Someone put a question up. Okay, great.
Sir, please, what's the name of the first type and the third type?
Okay, so this basically here is just esophageal atresia without without involvement of the respiratory tract. This is the H type. This is esophageal atresia with TEF. So this is esophageal atresia. This is OE atresia with tracheoesophageal this is the H type. H type. It's called the H type. This one is called the H type. Right. And then this is just complete esophageal atresia, or you can say bilateral esophageal atresia. Either of them is fine. How they test this in the exam, they will tell you which of them is the commonest among the three. They can ask you on that. The second way they can ask you is the presentation of this patient and the association, right? So they will ask you on the presentation. They will tell you that, oh, child was born, noticed to have cyanosis, and then the patient vomits with his first feed. So that word is high, very, very high yield. When they tell you a patient vomits, not within the first not within the first hour, not within the first 2 hours, not within the first week, not within the first day, but the vomiting is associated with the first feeding. So the first feeding could be the breast milk the mother is giving the child, basically. So vomiting with the first feed, and then they'll tell you that the child is drooling or choking. These three words, when you see it in the exam, I want you to think of esophageal tracheoesophageal fistula first. That's the first thing I want you guys to think about first. Then you can be thinking about that diagnosis. Okay?
Please, can you show us this on the first aid?
Okay.
Because some of us will only read first aid when you are teaching. Yeah.
Okay. So this is what I was talking about. So this is more like a pure esophageal atresia, and then this is the H type, and then this is the esophageal atresia with the TEF, right? The most common type basically is this. This is the most common type. That was what I was trying to tell you guys. This is the most common type that you need to know. What is most high yield for the exam? And I want you guys to pay attention to this. What is most high yield in the exam is the presentation. The presentation as well as the association. So when they tell you a patient is having vomiting with the first feed, choking, excessive drooling, please, I want you to think of esophageal atresia. Now, how do you confirm this diagnosis? It's a clinical test you do. You pass an esophageal tube, and then you discover that there's so much resistance, it can't even go through, right? Can't even go through. And when you see that, that there's a failure to pass an esophageal tube, along with this clinical presentation that I just mentioned, I want your mind to go to tracheoesophageal fistula. Now, basically what happens here with this bubble sign that you see, this prominent gastric bubble, is that as you breathe in, typically right now, when you do a normal X-ray, you see the gastric bubble. That happens because, of course, gas is lighter, and so food comes down, gas goes up, right? But for a patient with the H type, as far as there's a connection with the trachea, the patient will have a prominent gastric bubble, because even while you talk, you kind of like take in air and it goes down your esophagus. And so that's what causes the normal gastric bubble. But for these patients, every time that they breathe in, they take a large volume of oxygen, and some of them is diverted into the gastrointestinal tract, and you would see a prominent gastric bubble. You can differentiate radiologically the different types of atresia by knowing the prominent gastric bubble. You should know that the one that's a pure atresia or stenosis, the first one here, you won't see that gastric bubble because there is no conduit between the trachea and then the esophagus. Okay. Another thing you need to know, basically, is also very high yield, is that you need to know that this is part of the Vactral defect, right? You need to know this. This is part of the Vactral defect, although it can be tested. So basically, how they ask this in your exam is that they will tell you about the patient who has tracheoesophageal fistula, and they might ask you what other conditions can this patient be at risk of having. And so if you remember the Vactral symptoms, you know, you'll be able to go about that. Can anyone tell me about the Vactral? Okay, Zion, you have a question? Please, if you raise your hand, it's only just okay. Please, if you have a question, if you're raising your hand, you can just quickly ask your question. Then when you're done, you can drop your hand. If you don't want to raise your hand, you can just put the question on the chat. I will look at it and then I will answer it, right? There's no hurry, there's no pressure. So, Dr. Nishan, you're asking about the chromosomes from omphalocele. Yes, I said that there are 3 chromosomes. No, there are two chromosomal syndromes that are associated with omphalocele. The first one is trisomy 13 and trisomy 18. Trisomy 13 is Patel, and trisomy 18 is Edward. A simple way to remember it is that the England King Edward, in olden days Britain, if you want to become a king, you have to attain adulthood. And so to become an adult, you need to get to 18 years of age. And so you can just think of King Edward becoming 18 years, or King Edward became a king after 18 years. And that kind of like helps you to be able to kind of like differentiate between the both of them, because it can be confusing at times. Okay, so do we have any more questions so that I can move on? Okay, so the next thing we're going to talk about, one common complication of tracheoesophageal fistula, although it's not tested in the exam, but it might be a presentation. It's not tested in the exam commonly, but it can be a presentation of a patient with tracheoesophageal fistula, and that's cyanosis. This patient has cyanosis, and the reason why it's laryngospasm. So basically what's happening there is that gastric content is kind of like going, into the respiratory tract, and of course the way the body reacts. And it also happens when you are eating and you're talking. You start coughing out. You want to expectorate the food content, and you've noticed that you find it very difficult to breathe at that time. And the reason why you have that is laryngospasm as well. So cyanosis is a complication of tracheoesophageal fistula. And then they might also ask you in the exam that in utero, this patient or this baby had what condition? And basically, this patient will present with polyhydramnios. So basically, what happens in polyhydramnios is that the fetal urine constitutes about 80 to 90% of the amniotic fluid. And so the only way you can kind of like the only way you can how do I put it now? Reduce the volume of amniotic fluid is the baby. The baby has to swallow it, right? Has to swallow it. And so if the patient can't swallow, the patient can reduce the amount of amniotic fluid. So amniotic fluid is just being created, but it doesn't have an exit point. And so it will accumulate, and then the patient will have polyhydramnios. And that is a very high yield association that I want you guys to know for the exam. So we move on and we will talk about pyloric stenosis. And so basically what just happens is I told you that pyloric stenosis is one of the CHADS associations with Down syndrome. So that's the first thing you need to know. And then these patients tend to present with vomiting that is non-bilious. So basically what happens here, let me show you guys in the first aid. So what happens here basically is any obstruction you have at the level of the pylorus above would present with a non-bilious vomiting, and then any obstruction that is below where the bile duct and the pancreatic duct enters into the duodenum, an obstruction at that point can cause bilious vomiting. And so these patients, of course, pyloric stenosis, hypertrophic. So basically what's happening there is that the pyloric stenosis is gathering muscles or becoming hypertrophied. And so it's narrowing the exit point for the gastric content. And so basically what you would have is that this patient would have two things that are going on. This patient will have non-bilious vomiting that will take weeks to happen, right? It takes weeks to happen because it takes time for this guy to significantly occlude the gastric outlet. And so what you would see in the exam is the presentation. Basically in the exam is that they will tell you about a fetus that was born, 2-3 weeks ago, started having non-bilious vomiting, non-bilious vomiting. Please, can we mute our mics so that others can listen? Non-bilious vomiting, right?
Sir, please, can you explain more on the salivary glands, please?
Salivary glands, okay.
Yes, sir.
So let's start with salivary. Let's take salivary glands. So we have three types of salivary glands. I'm sure that you're aware of this. We have the parotid gland, we have the submandibular gland. These are the commonest one, right? Submandibular gland. And then we have other accessory glands as well, other accessory salivary glands. And so the parotid gland is the largest contributor to saliva production. And you know that saliva production is kind of like parasympathetic in nature. So parasympathetic innervation is what leads to more saliva production, right? The submandibular gland empties in what we call the Watton's duct. What is high yield for you to know about the ducts basically is the duct that empties. That's the first thing. Its location. And so the parotid gland is just located kind of like at the angle of the jaw. And then the facial nerve passes through it. So what it means is that you have a malignant tumor of the parotid gland, it will affect the facial nerve. That is one thing you must know. And so the Watton duct, the submandibular duct, is kind of located at the floor of the mouth, right? Floor of the mouth. And so the Watton duct empties into the oral cavity. And basically the saliva has like two functions. That's protective function and mechanical function. Mechanical function. So there are different part. We're going to talk about the physiology of the salivary ducts, or the glands rather. So basically, what you need to know about the salivary gland is that, let's say this is the gland itself, and then these are the ducts, right? What happens here basically is that when you produce saliva, it is initially hypotonic, is of hypotonic concentration. So when you produce saliva, it is hypotonic in nature, meaning you have all the electrolytes, sodium, chloride, bicarbonate, bicarbonate, you have potassium. So what happens here is the acid pass, this is the acinar cells that kind of like produce the salivary, the secretion basically. As the saliva passes through the ducts, what you have here is that you have kind of like reabsorption, you have more of like reabsorption of some certain electrolytes, right? You have some absorption of certain electrolytes here. And so basically, a lot of sodium is taken in, and then a lot of potassium leaves. And then a lot of bicarbonate goes out, and then a lot of chloride goes in. So the ductal cells are the ones that are responsible for this process. So more sodium comes in, more chloride comes in, but potassium leaves, and then bicarbonate also leaves. Bicarbonate and potassium leaves. Chloride and sodium enters into it. This pulls a lot of water and increases the concentration. And so by the time you're using your saliva, it is more isotonic than when it was produced. Because hypertonic means there's increased concentration. Isotonic means that it's the same concentration as the blood. And then hypotonic means it has a reduced concentration. And so when you have a situation where the saliva passes as fast as possible through these ducts, it means that there won't be enough time for this process to go on. And so you would have more of a hypotonic saliva if it goes through this duct as fast as possible, right? That's just about the saliva, physiology of the saliva. And of course, you know that the protective function, a lot of things are contained in the saliva. You have zygomens, you have IgA, you have a lot of proteins, proteases. These are things that help. You have a lot of enzymes, salivary amylase, you have the salivary lipase. So these are things that help with digestion, break the food into smaller quantities, make it more easy, so that digestion kind of like is seamless, basically. And that's the physiology of the salivary gland. The pathology basically is a different topic, and we'll have to take that towards the end of this class. Pathology is much more broad. We'll take it at subsequent towards the end of this class. When I'm talking about pathology, I'll talk about all of it, right? The salivary glands, as you know, are endodermal in origin. They're endodermal in origin embryologically. You need to know the parietal gland produces more saliva, but the submandibular gland tends to be a lot more larger. We'll talk about the pathology in the class. We have other things, but let me just summarize the pathology. So we have infective causes, we have obstructive pathologies. So we have infective pathologies and obstructive pathologies, right? So the obstructive one is where you have stones, right? You have ciliolithiasis. So basically, you have a situation where you have stones basically formed in the saliva. And so basically what happens here is that the saliva has to be isotonic, right? So that, you can have, it has to pass through the duct at a very steady rate, so that the hypotonic becomes isotonic. So what happens here is that the situation where the saliva is passing too slowly, it becomes hypertonic. And of course, if it's hypertonic, a lot of crystals, a lot of stones can be formed in that process because a very osmolalic uh, plasma or substance tends to have more stone formation. So the more osmolar something is, the tendency for stones to be formed. And so when you don't use your salivary gland or you don't use it frequently, there'll be a lot of stasis. The saliva, when it comes through the duct, goes out very slowly, and then there's hypertonic rather. You have a hypertonic saliva that helps to precipitate stones, and that can cause ciliary lithosis in the salivary gland. And if that happens, the patient will have pain, right? Pain, basically, in the salivary gland, or when the patient wants to feed, when the patient wants to feed, basically, because when you want to feed, looking at the food is a stimulus for the salivary glands to start producing saliva. And so when the patient looks at food or wants to eat or feed, the patient will be having pain, more like facial pain, right? More like facial pain. The patient can able to localize the pain more around. If it's the submandibular, if it's the submandibular, it's at the lower molar area, and if it's the parotid, it's at the upper molar. Then there are other accessory ducts that can be blocked, and you have pain there. What now happens basically is that if there is now gathering of this fluid and there's now infection, you now have what we call ciliary adenitis. Ciliary adenitis basically is a situation where that saliva forms a state, and I told you that saliva has a lot of things. It has protein, it has proteases, it has enzymes, that are there. And some of these enzymes, if they're not produced, the saliva can form a kind of like nidus for infections to go in. And common infections that causes ciliary adenitis are more of the normal flora in the mouth. So you can have Staph aureus, which is a common cause of ciliary adenitis. And then, that's basically what we have for the infective causes. The obstructive causes are the stones that I mentioned. The infective causes are the ciliary adenitis. And then you can have tumors. Very good tumors you can have is the pleomorphic adenoma that is commonly tested in the exam, where you have numerous glandular cells, and then you have proliferative stroma around that disorganized glandular epithelium in the salivary gland. We'll get to that when we talk about the pathology more. This is just something I just want to discuss with you guys here. I don't know, does that make sense? Okay. Zaib Ali, I don't know why you're giving a thumbs down. You don't understand it, or I don't know. Okay, so I'm not going to take any questions anymore till I'm done with the topic. I only have an hour. In fact, I've already exhausted the hour. I'm not even done with embryology. I'm just trying to make sure that everybody's carried along, right? So the next thing I want to talk about is the hypertrophic pylori. So basically, I talked about the presentation, right? I talked about the presentation. I said that the patient will have vomiting with feeding, drooling, and choking. And then the patient will have non-bilious vomiting that occurs maybe a week or two after birth, right? And the one thing you need to know that is very tested in the exam is the risk factor for hypertrophic pylori stenosis. You need to know that macrolide exposure. So basically, how to put the question is a woman who had maybe an infection in pregnancy, took a macrolide, maybe erythromycin or clarithromycin, and then the child later, when she gave birth, 2 weeks later, the child started having vomiting, feeding, drooling, and all those kind of things, non-bilious vomiting. And so that's something you have to know. Another thing you have to know that is very, very characteristic is that they will tell you in the STEM question that the patient has a peristatic visible peristalsis and an olive mass. So let me explain what this means. So basically, this visible peristalsis you are seeing is that the stomach is contracting with so much force. It's contracting with so much force to kind of like go over this obstruction. And so that force is transmitted to the skin, and that's why you're seeing the visible peristalsis. Because of the hypertrophy of the pylorus, it forms like a mass. So you would think it's maybe a malignancy and all of that, but it's not a malignancy. You see an olive mass. That description is high yield, olive shaped, very, very high yield for the step 1. Olive shaped. When you see that in a STEM question, it could be only one thing. There is no other GI tract abnormality that presents with an olive shaped mass. There is no other one. If you see an olive shaped mass in your STEM question, I can almost bet with everything that I have that that person, that child, has hypertrophic pyloric stenosis, right? Now, of course, like you said, like I said earlier on, that the stomach is trying to push this thing towards here. What happens if this obstruction persists? There's only one outlet. There's so much pressure. There will be a buildup of pressure in the GI because the stomach is trying to contract against this resistance. And so the patient has no other alternative than to, go to the place of least resistance. When there's so much pressure, the content will have to go through a part of least resistance. And that's why you have the non-bilious vomiting. It's usually very projectile because the pressure coming from the walls of the stomach is trying to overcome this pyloric stenosis here, will cause the content of the GI tract to go through the stomach, and it goes with so much force, and so the baby has projectile vomiting. The risk factor, the patient is exposed to macrolide, and it has a very weird gender prevalence. It's more common in male children at a ratio of 4:1. So for every one female child that has hypertrophic pyloric stenosis, you have 4 male children that are affected. Now, what is the abnormality as regards electrolytes? So basically, what's happening here is that the stomach has a lot of acid, and so you are losing a lot of acid, a lot of fluid, a lot of hydrogen chloride through the stomach, right? While you're vomiting, right? Now, what happens here is that the parietal cells will have to form a lot of more hydrogen chloride. And so let me show you let me demonstrate this with a picture so you can understand this much better. So this is what we have here. This is the stomach, this is the stomach here. So you're losing a lot of HCl. HCl is being lost. And so the parietal cells here that line the stomach would have to produce a lot of HCl. They want to increase the HCl production. You know that the stomach contents, HCl is made up a lot of water, right? A lot of water. And so the parietal cells, how do? They take a lot of hydrogen inside here and take a lot of chloride inside here. And what do? Chloride has to be exchanged with something. Anytime chloride goes in the opposite, goes in one direction, a negative ion must be exchanged for it, right? And that negative ion that is exchanged for it is bicarbonate. And so bicarbonate goes into the blood. And so the patient has, when there's so much bicarbonate, the patient will have what we call alkalosis. That's why you're seeing here that the patient has what we call metabolic alkalosis. It's metabolic because there is more bicarbonate being produced, right? There's more bicarbonate being produced. If there's more CO2 that's being produced, it's more of a respiratory alkalosis. If there's more CO2 that's being expired, what you have is respiratory alkalosis, respiratory. But because there's more bicarbonate, what you have here is metabolic. Now, what happens in this basically? And so this gets to the blood, and there's a very elevated level of this. Now, there's another problem that's happening here physiologically. This patient is not only losing hydrochloric acid, he's also losing water. And this kind of like drops the effective plasma volume. And when there's a drop in this effective plasma volume, the kidneys are able to sense this. And what does the kidney do? The kidney helps to activate the RAS, right? Helps to activate the RAS. Also, you need to know that hydrogen is being taken into this place here. And if hydrogen is being taken into the stomach, it will decrease the concentration of hydrogen in plasma, and that also contributes to the alkalosis. But the effective plasma volume is reducing, and so RAS is activated. What does RAS do? Aldosterone is produced. What does aldosterone do? Aldosterone helps to reduce hydrogen ion and also potassium as well. And it does this in exchange for sodium and water, basically. And so this patient will have hypochloremic, because of course you're taking a lot of chloride inside the stomach, so it'll be hypochloremic. They'll be hypokalemic because the kidneys are removing a lot of potassium. And then there'll be metabolic alkalosis because there's a very high level of bicarbonate in the blood. And so how do you treat this patient basically, or how do you diagnose it? You do an ultrasound scan. The ultrasound scan will show you the thickened pylorus. Will show that it's lengthened and it's also thickened. And then when how do you treat the patient basically? You treat the patient by doing an surgical incision on the pyloric muscles. So you call it a pylorotomy. That's what you do to kind of like salvage that situation. Is it clear, guys? Are we okay? So yeah, so let's continue, guys. Now we're going to talk about intestinal atresia, and after that we'll be done with anatomy. We'll be done with embryology. So I want to talk about atresia, intestinal atresia, I can group it into two parts, right? I can group it into two parts. So I can group atresia into two parts, right? Atresia, I can group it into two parts. So we have atresia or intestinal atresia. Let me just write atresia. We have the duodenal, and then we have the jejunal, and the ileal. Now, what happens in this condition? Like I told you guys earlier when I was talking about the hypertrophic pyloric stenosis, I mentioned that this patient, because it's at the level of the pylorus, they will have non-projectile vomiting. But here, what happens basically is that the duodenum around the 9th week, 7th to 9th week, undergoes both the muscular layer, the epithelial layer undergoes a lot of hyperplasia basically. So a lot of cells are formed around the 7th week, right? That kind of like blocks the duodenum temporarily. So around the 9th week, this blocked place has to be recanalized. So there's a blockade by cells here. And so around the 9th week, signals are sent to produce a lot of kind of like proteases that come and kind of like destroy these cells. And then apoptosis also occurs that cause these cells to die off. But what happens is that if those two processes do not occur, so processes don't get to that place to kind of like destroy those cells, then apoptosis does not occur. There will be a failure of recanalization of this area here, and you have what we call duodenal atresia, and this occurs around the 9th week. Around the 7th week, cells kind of like undergo hyperplasia in the duodenum and block a part of the duodenum temporarily. And around the 9th week, signals are sent to the duodenum to cause apoptosis of these cells here. That's programmed cell death. And when those cells die, proteases are supposed to come and mop up those dead cells. And that leads to what we call recanalization of the duodenum. If there is a failure for that to occur, you would have what we call duodenal atresia. And of course, it's occurring in the duodenum. It means that this patient's vomiting would occur typically very early, right? Because the duodenum is very small. It's very small. It's a very small tube, as against the hypertrophic pyloric stenosis that has a very large stomach. So some can be kept in the stomach until there's a buildup of pressure and the patient vomits. But in duodenal atresia, the pipe is very little. Hence, the patients kind of present earlier. And then these patients tend to have what we call bilious. It's bilious because I told you anything below the pylorus, any pathology that occurs below the pylorus will cause bilious vomiting. And so this duodenal atresia that we're talking about can also be associated with Down syndrome. So you can add this to the Chad mnemonics. Just add this to the Chad mnemonics. So CHA D. So this D, you can put a square here. So this can be diaphragmatic hernia, or this D can be duodenal atresia, right? Duodenal atresia. You can do that, make it easy for you to remember and all of that. But this guy over here basically has a problem. And the problem is that the blood supply to the kind of like the mid-gut is by the superior mesenteric artery. And so it's actually a vascular occlusion of this artery. And so if the duodenum does not receive blood from the superior mesenteric artery, that place will undergo necrosis and ischemia. And what will happen? The body will come here, kind of like resorb this place, and what you have is something like this instead. So you have a space because the body has resorbed here. Macrophages have come to kind of like take up dead cells here, and of course healing will occur, and this is what you have. And so anything that will cause ischemia, maybe an occlusion or whatever during childhood, or vasoconstriction around this place, leading to reduced blood supply to an area of the jejunum or the ileum, can lead to jejunal atresia, right? And this is commoner in women who smoke or use cocaine. And this is very high yield. And that is how you would know in the exam. This is a very high yield association, smoking and cocaine use for jejunal atresia. Does it make sense, guys? Okay. So let's go on to the next one. Yeah, so we have the pancreas and then the spleen.
Excuse me, please, is there any age like associated to this abnormalities?
You mean age abnormality?
Yeah. Is there any age as a, like the one of hyper, like the one
Hypertrophic
of
pilocysts.
hypertrophy that has to do with a child, and now you're talking about this
They're all in children.
this,
All these occur in children. They don't occur in adults. They mostly occur in
okay,
children.
all occurs in children, but you talked about smoking, so it has to be the mother.
Yes, it's the mother that smokes. It's the
Smoking
mother that
during
uses.
pregnancy. Okay.
Yes. Yeah. Thank you for your question. Can I repeat the electrolyte abnormality? Okay, after the class, I'll do that. I have to try and like round up this biology so that we can go. So we're going to talk about the pancreas. I'm just going to talk about the pancreas basically. Pancreas, endodermal. The spleen is mesodermal. The pancreas comes from the endoderm. And then the spleen comes from the mesoderm. Right? I think it comes from I think it should be the dorsal. Yeah, it's supposed to be the dorsal. Yeah, so it comes from the dorsal. So it's very important. It comes from the dorsal mesoderm. That's high yield. Dorsal mesoderm. The pancreas comes from the endoderm. And so there are basically two abnormalities with the pancreas that you need to know. The first one is annular pancreas. I'm just going to explain that basically, right? Embryologically speaking, this is how the pancreas kind of like is formed, right? Let me just explain it with a diagrammatic sketch here. So let's say this is the duodenum. Let me use the duodenum as an example. I want to explain what happens. This is the duodenum, right? This is the ventral part, and let's say this is the dorsal part of the pancreas. This is the dorsal board, the ventral board. Now, what happens in annular pancreas is that ideally, the dorsal board is supposed to meet the ventral board. So let me label here as V and D. They're supposed to meet themselves, at this small route. This is the shortest route for them to meet themselves. What you have here is a situation where the dorsal part of the pancreas, instead of taking this short route to get to the ventral, sends tissues like that grows in this direction. And so what happens? It kind of like compresses on the duodenum, and so these patients can kind of like present with signs and symptoms of intestinal obstruction, because instead of it taking the shorter route where it doesn't like compress on this side here, it stays here and then sends tissues that go across. So instead of just going at an angle of maybe 90, it's going at like an angle of over 270 basically. And so it will be compressing the duodenum, and this will cause annular pancreas. And if you remember my child symptoms, my child association, you know that this is associated with Down syndrome, right? Embryologically, this is how the pancreas is formed. So let me just draw it so you guys can have an idea. Embryologically, this is how the pancreas is formed, right? So what you have here is that the ventral part forms the main pancreatic duct, right? And then the usinate process. This is usinate process. This is the main pancreatic duct. So let me write main pancreatic duct. The main pancreatic duct. And it forms the usinate process. This is the ventral. These two are gotten from the ventral. These two are gotten from the ventral, are gone from the ventral board. So it has two boards that form the pancreas. And then there's a duct in the usinate process known as the accessory duct. This accessory duct, as well as the body, is formed by the dorsal board. So this guy now joins here, dorsal board. So the body of the pancreas, the tail, and the accessory duct is formed by the dorsal board. Now, what happens basically in a condition known as pancreas divisum? What happens in pancreas divisum is that there's a failure of these two ducts, these two derivatives to come together and join together, like come and combine and form the pancreas. So what will now happen is that you would have two separate structures, or sometimes you can have one together, but the main pancreatic duct is supposed to empty, right? Two of them are supposed to meet together. This main pancreatic duct and accessory duct are supposed to meet together and form the common pancreatic duct. But because they don't join together, there's a separation. Hence, what you would see is that the patient's accessory duct will be draining into the duodenum separately from the main pancreatic duct. Now, here's the problem. The problem is this main pancreatic duct, if it doesn't join with this one, it means that there's a space here. Let me show you what I'm talking about. It means that there'll be a space here between the accessory duct here and this pancreatic duct here. So it means that this common pancreatic duct will not be formed, or might just be formed by only the accessory. I don't know. Does it make sense, guys? This accessory will now form the main. It's now what will now form the main common pancreatic duct that will be draining this pancreas. But here's the problem. All the secretions in this region here will not be able to drain out. And so God, mercifully creates other ducts, accessory ducts that can drain the pancreas out. What will now happen is that these other ducts that are draining all these secretions out do not have the capacity to drain it as much as the main pancreatic duct. And what will this lead to? What will this lead to? It will mean that the pancreatic enzymes will stay in the pancreas, and you know that that's not good for the pancreas. If the pancreatic enzymes are not secreted, they stay in the pancreas. They have a tendency of auto-activating themselves. So the pancreas the pancreatic enzymes can actually activate themselves. There's a name for that. Because they can auto activate themselves, they will cause what we call auto digestion of the pancreas, and that can lead to pancreatitis. And so that is what happens in patients with pancreas division. That's what you see here, basically. So they were having symptoms of pancreatitis and all the likes. Does that make sense, guys? Does it make sense at all? So,
Sorry, can you use what's gone? The picture on the first aid to just explain, because the diagram here is not so.
I hope we have a picture here. If we don't, I don't think we have a picture here. But let me use this one that I can see here. I have one here that I can use. So you can see what I'm trying to tell you. What I'm trying to say basically is this. The main pancreatic duct, this main pancreatic duct here, and you can see the main pancreatic duct as well as the usinate process is gotten from the ventral board. The body of the pancreas and the minor papilla or the accessory duct is gotten from the dorsal board. What basically happens here in pancreas division is that these two are supposed to, you can see that this one was here, this one was here. This guy is supposed to come and join this guy here, and their ducts are kind of like supposed to fuse and form kind of like the common pancreatic duct, right? But you can see right here that these two structures do not fuse. And so you can see that the two ducts do not form the common pancreatic duct. But the problem here that we have for the main pancreatic duct is that if they don't fuse, the main pancreatic duct is kind of like docile. It's basically non-functional. And so a lot of workload will be given to this accessory duct here. And there are also accessory ducts that are located in the in the body of the pancreas. And so those are the ducts that will be more patent. But the problem is the main pancreatic duct is the main duct that drains the body. And if it is docile, it means that you have a lot of secretions that are left, maybe in the tail or somewhere. And so those things can cause autodigestion because the pancreas is an organ that it produces a lot of its pancreatic secretions. And those secretions go through the main pancreatic duct in about 80% of the time, right? And if that, just imagine that doesn't happen, it means that a large portion of the pancreas will be drained. And if a large part of the pancreas is not drained, the enzymes will stay in that body of the pancreas and cause autodigestion. And if they cause autodigestion, the patient will have pancreatitis. That's what I'm trying to say. The other thing I was trying to say at the same time is that the accessory ducts that are now functional, that are, like kind of like functional basically, they would become excessively dilated because they are taking a lot of secretions from the body, and that's not their job. So that's what you see in a patient that has pancreas division. I don't know if that makes sense though. Does that make sense at all?
Dr. OS,
Yeah.
I have a question. When
Yeah,
you
go
say
ahead.
pancreatic dehiscence, I thought dehiscence is like a tear.
No, divisum.
Oh, division. Okay.
Yes. Now, the last thing, Sasha, please, can we mute our mics, please? I was talking about the electrolyte secretions in hypertrophic caloric stenosis. Now let me just do this. Please, can we mute our mics? I said that the patient is losing hydrochloric acid. Right? It means that in the stomach, hydrochloric acid is being lost. So what does the body do? What does the body do? The body does two things. It stimulates the parietal cells to produce more hydrochloric acid. And how does it do that? You don't have to take in a lot of hydrogen. You have taken a lot of chloride. But the problem is that if you're taking a lot of chloride in, you would make the acid secretion overly negative. So another electrolyte has to leave, and that electrolyte is bicarbonate. If bicarbonate goes into the plasma or the blood becomes more alkaline, and so the patient has metabolic acidosis. Metabolic alkalosis, sorry. Now, you're losing chloride into this place. You're taking chloride and hydrogen into this place. When you take hydrogen into this place, it also drops the hydrogen ion. So it makes the blood more alkaline when you take a lot of hydrogen out. But the problem here is that, of course, you're taking a lot of chloride inside, so it makes chloride drop. So the patient will have hypochloremia in blood. The patient will have hypochloremia in blood. The patient will have hypochloremia in blood. And what does the body do? You are losing hydrochloric acid. Hydrochloric acid has a lot of water. So what happens? The patient becomes dehydrated, and effective circulating blood flow or blood will be reduced. So effective blood flow will be reduced. So how does the body act? The body now releases what? RAS, renin-angiotensin system. Activates it rather. When you activate RAS, what happens? A lot of aldosterone is produced. What does aldosterone do? Aldosterone will cause retention of sodium and water. To cause retention of sodium and water. There'll be retention of sodium and water. And there'll be loss of potassium. There'll be loss of hydrogen ion, right? And then this patient will have what we call hypochloremic, hypokalemic, metabolic alkalosis. That's what I was just trying to say. Okay, so we'll stop here today, guys. Do we have any questions? Any questions?
Yes, please, Doc. Please, I'll take you a little back with regards to the salivary gland.
Yeah.
So, please, I want to ask, what could cause stones to form in the salivary gland, please?
Yeah, so I mentioned earlier on that when saliva is produced in the acinar gland, the acinas are like pockets, outpouchings that help to produce saliva. The epithelial cells lining the acina causes that. And so what happens is that when you don't use your salivary gland a lot, it kind of accumulates, because basically when you use your salivary gland, those acinar cells push the newly produced saliva into the ducts. Do you understand what I'm trying to tell you? And in the process of producing that, pushing it into the duct, the what do you call it? The saliva becomes isotonic. So the saliva you and I make is similar in terms of concentration to what we have in plasma. But when there is stasis, or you're not producing a lot of saliva, basically, that salivary gland that is hypotonic, we have a lot of potassium, a lot of electrolytes going into it, and it becomes hypertonic. When something becomes hypertonic, it enables the precipitation of stones. Do you understand what I'm trying to tell you? When something, for example, you don't drink water, for example, now, if you don't drink water in a very arid environment, you'll be dehydrated, right? Okay. You become hypertonic. Okay. You become very, very hypertonic, basically. And when you're hypertonic, it creates an environment where stones can be formed easily. Okay. Do you understand what I'm trying to tell you?
All right.
So the fact
So
that it's not
how
leaving,
about okay? Mm,
the fact that the saliva is not leaving the acinine, not leaving the duct, can predispose it to can predispose it to be hypertonic, and then can predispose it to having stone formation.
okay. So can one say fasting it could be a risk factor?
It depends on the kind of fasting. It depends on the kind of fasting, basically. Yeah, if somebody is fasting 40 days and 40 nights without eating, obviously, the chances of getting stone formation will be high, right?
All right.
As
Thank
against
you.
somebody who, of course, fasts for a period of time and then eats. You know what I mean? And then another thing you need to know, basically, is that when you see the site of food, seeing the site of food causes parasympathetic stimulation to the salivary gland, and then you produce saliva.
Okay.
Yeah.
All right. Thank you so much.
Yeah. Okay, guys. So, in the absence of any question, I'll see you guys tomorrow. We'll be starting anatomy of the GI tract. Very, very high yield things you need to know here. And after anatomy, we'll do physiology. We might do anatomy and physiology, pathology. It depends how fast we can go. Okay. So you guys have a lovely day, and we'll see you tomorrow.
Our slideshow for
Yeah, I'll do the
reproductive.
slideshow. Yeah, I'll do a slideshow with you guys tomorrow. Unfailingly.
Thank you.
Yeah. And I'll give you guys the slide as well. Okay. GI honestly supposed to take 3 days. So if all things being equal, it's supposed to take 3 days. Okay.
Thank you.
Yeah.
Thank you.
Yeah.
Thank you.
Please, is the class over?
Hello? Hello? And then cancel.
Everybody's here.